Well, this is a great program so far. Feedback? Is it? All right. Great program so far. I'm enjoying it. It's been so inspiring. There's been this emotional swings up and down related to trying to make sure that women have a better opportunity. That women, every day we wake up trying to be women in this world. And I just tell you, it's, you know how difficult it is. But we need our allies, so we need our men to be beside us. I am at Allegheny Health Network at Highmark, and I just need to start there for just a second to kind of frame what that means as far as diversity, equity, inclusion. Because right after George Floyd, you know, people were hiring these officers all over the country to really come in and try to figure out how can we do better, how can we be better as organizations. And so I'm the inaugural diversity, equity, inclusion officer at Highmark. And what they did was they decided to invest $100 million in diversity, equity, and inclusion. Now remember, Highmark is a pretty wealthy organization. It owns a hospital system. One of the large blues in the country that is a payer that actually owns a clinical space. So they own about 14 hospitals and all these clinics. And they had to figure out how do you really do this DE&I stuff, being a payer, as well as a clinic and having this clinical space. So they invested a lot of money into this, but which tells you how you need to do it right. Now, I don't think you need $100 million to start with, but I think that funding something that is so important to your vision and mission is critical. They let me build a really large team of folks to work with me, but all of those people who came to work with me, many inside and outside, not one of them had any training in diversity, equity, inclusion. They were mixed. I have Latino, I have Caucasians, I have a Filipino, but none of them had any training. They had the passion. You can't do this with just passion. You have to read. It has to be evidence-based. You have to understand as learners, of course, that you want to make sure you can defend what you talk about. And you can't have these uncomfortable conversations without having some empowerment through the knowledge. So part of the curriculum has to be, how do I empower myself to be an advocate for whatever today for women? So I say that just to kind of give you the background of, in order to do this job and do it right, you need both financial support, workforce support, and the passion to make it happen. That's the opportunity they've given me here, and I'm going to share a little bit about what my passion is and why I'm in the space, and talk to you a little bit about why we're in a crisis. And so I'm going to start there. Did any of you have the opportunity to look at the film Toxic at all? Great. We'll just chat a little bit about that a little later on, but that film was done in Cleveland, and it was done as part of a program that I was involved in there, and I'll tell you how we got there. So on the pointer, where's the pointer right here? The pointer is where? It's on there. I see it. Great, I found it. Okay. This is Connie. This is Corbin, Chase, Carson, and Carlos. Connie and Carlos have been married for 23 years. They have these 3 wonderful children. Both of them are full-time employed educators, master's prepared. They live in the Washington, D.C. area, and so they're middle class. And they have had a significant journey that I want to tell you about. Because as healthcare providers, as leaders, as educators, and as our next leaders in medical education, this whole issue of how we make sure we give the best care, especially to women, is something we need to focus on. So Connie had Corbin at 34 weeks. She had insurance. She went to her office visits regularly, took care of herself. Her husband went with her regularly. But her husband was also often said, it's very odd to see a black male come in with a black woman. Can you imagine? Never asked him any questions about how he was doing or what he had to do with the pregnancy at all. And so how many times have you been in a space where you've never even talked to the significant other? Asked him questions that really involved his families. I've been there. Then, so her first baby, 34 weeks, she goes into labor, and she's got elevated pressure. She came in with a headache, just severe preeclampsia. On duty was her physician who was at home, but taking care of her was a midwife. Carlos calls the physician and says, they're telling me, another physician, they're telling me that the baby is having these really large dips in the heart rate. And they may have to take her to have a cesarean section if the baby doesn't look any better. And so I'm really scared. So that physician called her physician to see what was going on because he wasn't in-house. Severe preeclampsia, baby in distress, he wasn't in-house. And that physician, her physician, told the other physician that nothing to worry about. It's okay, it happens all the time, right? But at the time didn't realize that the physician was me. And I said, well, Connie and Carlos trust you. If they trust you, I'm going to trust you. Sounds like she has severe preeclampsia. Sounds like the baby may be in some distress. But if you think it's okay because you're there, then I'm going to trust you too. So what do you think happened? How quickly do you think he got to the hospital? Right? But another couple may not have had that advocate. I was the advocate for Connie. So she had Corbin. Corbin, you see how short Corbin was? She is now. She's 5 feet, right? So they think she probably had some intrauterine growth restriction at that time, right? And but probably had symptoms before. And but she's healthy. She'll be 21 next week, and she's a pre-med student. So Chase, Connie goes to the same physician, but she's delivering at a different hospital this time. So she goes into labor. She has the baby, no problems whatsoever, great delivery, except she was delivered by a midwife, even though she said she had a private physician, because she did not have private insurance. She was on welfare. Now, why would she be on welfare when they both were both of them employed? Right? She wasn't on welfare. It was an assumption that they made. It was an assumption that they continued to make the whole time she was there. She was assigned to the midwifery practice, even though she said she had a private physician and who he was, but they didn't listen. So she has the baby. Her physician is now upset because he wasn't called in for the delivery. She's upset because the way she was treated. And she said she was treated very differently. An insured individual versus someone who's not insured. So she calls me in after she delivers the baby, and she said, the nurse wants to speak to you. And I say, why? She thinks I'm bleeding too much. Where's the doctor? Where's the doctor? Well, the doctor's not in, but there's a doctor on call. The midwife delivered her, so I get this whole story. And I said, well, tell me about the bleeding. Soaking the bed, get up, I walk around, I'm bleeding. The nurse said, I'm bleeding too much. I said, well, where is the doctor? The doctor's on call. She's called the doctor, but the doctor said that she's busy. She'll get to her in a little bit. And I said, so I talked to the nurse. She's telling me how much she's bleeding, and I think, okay, this is a problem. So I call the doctor, and I say, this is Dr. Pettigrew. But for some reason, they don't hear that. This is Dr. Pettigrew. What they heard was, I'm the mother-in-law of Connie, right? And so I begin to say, Connie called me as well as her nurse and told me that she thinks she's bleeding too much and that she might need a D&C. And the doctor said to me, what? I'm the doctor. I will decide if she needs a D&C, right? I'm going to take care of her, but I'm the doctor. The ego came right out. And I said, okay. And what did I say? Well, I'm Dr. Pettigrew, an obstetrician gynecologist, and that's my daughter-in-law, and they said she's bleeding too much. So I'm going to trust you because she trusts you to take care of her. And there's always silence after that, right? Right. Thank you. We hang up. I call back 15 minutes, and where is she? She's in the OR. She's in the OR. What do you think her hemoglobin was? 4.3. So near miss, right? 2 near misses. Can you imagine? Okay. Carson ends up delivering on time, no issues whatsoever. But the entire time, what do you think Carlos and Connie are thinking? I don't trust this system at all. We don't know what's happening. They're not talking to us. They assumed that we're not, that we're the stereotypical African-American family. They don't even probably think we're married. I mean, this distrust coming out because of what they experienced before. But Carson had a nice normal delivery, Carson. And then what happens to Carlos? Carlos wakes up one day and he can't get out of bed. This young man is a teacher. He's a coach. He owns several lacrosse teams. He can't get out of bed. His wife calls the EMS service, and they come. And they talk to him. And they say, your pressure's up. You've been to the doctor recently? Yes, I have high blood pressure. You need to take care of your pressure. Had a conversation with him, and they leave. What do you think happened to Carlos? He what? Had a stroke. This is my son who had a stroke at 44, who was left at home in his bed, and he told them he could not get out of bed. Horrendous. This family. How much trust do you think they have in this system? How much trust do you? They are at a nice economic level. They're, 2-parent household, wonderful children. They have no faith in the healthcare system. So let's talk about why we also have this problem with mothers dying and babies in this country. I start with that because, trust is the secret sauce. I'm going to tell you about that a little bit later on. We're not going to get anything done if we don't build trust in our communities. And this is just a picture of some of the things that we've seen throughout the news, right? This was the New York Times. Can you see? What about this young lady? Did you hear this story? Right? They left her there, just like they left my son there. They told her she couldn't afford an ambulance. And she died. What did she die from? Severe preeclampsia, postpartum. And what about Kira? Did you hear about Kira? This is at Cedars-Sinai. This is the biggest story that hit the press. Mr. Johnson he testified in front of Congress. He's been on various news programs talking about the distrust he has for us, because of what happened to his wife. Wonderful couple. I think he works in business. She told them that she didn't feel well. She's at Cedars-Sinai. She told them that she was bleeding too much. And what did they say? This is normal. 10 hours went by before she went to the OR. She died on the table. 10 hours in that room with a brand new baby and her husband saying, something is wrong. And they didn't listen. It happens more often than you think. It's the voices that we keep ignoring. So I have no disclosures. And here's what I'm going to talk to you a little bit about today. I'm going to talk to you a little about statistics and what's happening with moms and babes, so you can see that this is a universal problem. It's not just here. It's not just at Case. It's not just in Pittsburgh. But this is a national, international crisis that we have. And I'm going to show you the statistics. I'm sure many of you have seen the statistics before. Just as an education piece to remind you that you have to know the statistics so that you can be an advocate. Because you've seen this. You'll say, I've seen this. I know this, right? We have enough data. We call it data justice. Data justice is when we have enough data, we just don't act on, right? So we have plenty of data to tell that this is a major issue and that we need to do something about it. I'm going to talk about some of the root causes of disparities. One of the big things that we're doing, I've been doing all my life, is saying, how did we get here? And in order for us to move beyond this space, without shame or blame, we have to know how we got in here. We cannot ignore the history because it's going to repeat itself. And so one of the important things is to understand why there's the root causes of disparities, and then some of the things that we can do collaboratively to try to decrease these numbers, and some best practices that we've done so far. So look at the bottom baseline. This is where we started. And in 2018, 17.4. Look at our target. We wanted to decrease 15.7 for 100,000. Look at the 2021, where we've gone. Amazing. So this is a definition that we talk about all the time. We know what maternal mortality is. But what you need to see on this slide is that the number of states, less than 50 of these states, have actually adopted MMR and have actually put together a committee to look at what's happened to moms, what are the deaths of moms, especially Black moms. Now, know that although the focus is to decrease the death of Black moms and babes, and primarily we're concentrating on babies because we know that will save moms as well. If we decrease the death of Black moms and babies, we decrease the death of all moms and babies by their interventions. In this country, it should be zero. We should not have any deaths from preventable causes because we were the richest, right? One of the richest. But know that we have to think about the political determinants of health that result in the social determinants of life. Because it's not just in our own four walls, it's about what's happening in our political space, in our legislative spaces, and what has happened over the many, many years as it relates to racism, sexism, all the isms that make a difference in the lives of a lot of people. But when you talk about the fact that we still have multiple states that won't even look at the causes of the death of some of the women, that's a problem. I was listening to Sharita when she's talking about how different things are happening related to Roe versus Wade in multiple states and how the governance is so different. We are so divided, and we've been divided for a very, very long time. There's a book called White Over Black that I refer to a lot, and it talks about colorism. We talk about racism now a lot, right? There's the issue of colorism that started way before racism, and that's in the 1500s. It's called White Over Black. And if you follow that pattern, and this just didn't happen in the United States. This happens all over the world and still does, where people are minoritized because of how they look, because of the disabilities they have, because they're part of the LGBT population. And that happens all over the place. So look at this. Look at these stats. Look at where the U.S. is, 23.8 when we talk about M&M. And then look at New Zealand, 1.7. So if you go down the scale here and you think, oh my goodness, look how the big gap is between the U.S. and New Zealand. So what if I put another column over there and I said, well, let's talk about the percentage of people of color that live in those countries. If I didn't put any numbers, I'm going to tell you a few of the numbers, but if I didn't put any numbers over there, what would you come up with? What would you think? The lower the number of people of color, the better the outcomes for women. Interesting, isn't it? Right? If you start at the U.S., we have about 14% in our country. As you move all the way down to New Zealand, you have less than 1%. Think about that. Causes effect? No. But it's something to think about because there's so much material that's out there that says that we need to really start to look and see one another authentically for who we are. And if we don't address this issue of racism in an open space where we can talk about it, or we can talk about coming from these different lived experiences, things will never change. So this is what's happening right here in the States right now. Women 3 to 4 times more likely to die from pregnancy-related causes than white women. Twice likely to suffer from severe maternal morbidity. Now, that's morbidity, not mortality. So we're talking about women who are leaving the hospital in renal failure, women who have long-term chronic diseases after a delivery, who come in who are healthy. And so if you look at the places that in this country that has a large population of people of color, they have the worst outcomes. Look at Mississippi. White women 29 versus black women 54. Unbelievable. So we can't have this conversation without talking about that elephant in the room. So get comfortable, take a deep breath, right? I'm not calling anybody racist because that's not something we won't do. What I am saying is that we have had different lived experiences. Those lived experiences have created behaviors in our lives that sometimes are not good for folks. That we need to take a look and really think about who we are, because it all starts here. And if we're going to change this, it starts here. And it starts at our large systems as well. So just put that in the back of your mind. All right, so I can show you this all day about where we are as far as the U.S. mortality rates from 2018 to 2021. But what you can see across the board, look at black, look at white, and look at Hispanic. They're all doing what? They're all going up. They're all going up. No one is escaping this issue, this crisis. No one. African Americans and blacks in this country is higher, but every single one of these groups are dying from preventable causes. So when I talk about let's do this together, we have to do this together. And when I talk about everybody has to be at the table, I ask this question a lot. I say, who in the room has an ethnic background, has lived in a very diverse community, right? And who lives in a very diverse community? Raise your hand. Get a few hands, right? A few hands. I'm going to tell you those who are, I'm up here, I'm looking out there. The people who raise their hands is one black man, one white man, and like 3 other people of color raise their hands, right? But from my memory, I think we all came here and got here on some kind of a boat. Am I right? Okay. And in our communities, we have people who maybe look like us, but they've come from different backgrounds. So we have people in our own communities that come from ethnic backgrounds. But when we don't see that at all, because we don't see people as they really are. So who in here comes from an ethnic background and has and lives in a diverse community? Let me ask that question again. Many more hands go up, which should. Because the minute that we begin to think about every one of us coming from lived experience, whether you live in an all-white community or all black community, we've all had different lived experiences. And the way we behave based on those experiences is what can help or hurt other people. Because bias kills. We know it kills. All right. So this is the black-white ratio in the United States. And see where African Americans or people are black versus whites, right? But it's still a steady state. There's no change. We've had decades of women and babies dying. Decades. All right, let's talk about when people are dying. When are we losing the lives of moms and babes, right? So the biggest is you think about maternity deaths during pregnancy. My great MFM folks, who I work with really, really closely, and in this space, what happens in that prenatal space? What happens when you have preterm deliveries, preterm deaths, mothers die, etc. And that's during the pregnancy itself at 31%. Delivery. We always think things happen at delivery that's really critical, right? Women, a lot of women are dying, a lot of babies are dying. Not so compared to what's happening in the pregnancy process, prenatal. It's only 17%. But look what happens postpartum. That 4th trimester. You know that 20% of the deaths in postpartum occur secondary to what? Suicide. Isn't that interesting? Where's my mental health person? Yes, think about that. Think about that, 20%. What? Postpartum. So what does that tell us as a community? That this is where we need to focus, right? All of these areas, but we're not that village, obviously. Again, if we look at where everybody is, you still see that increase, right? You still see the increase in everybody. So we're all in this together. This is the point I need to drive home to you. That this is a crisis, and it's a crisis for all of us. It's a serious crisis for African Americans and blacks in this country. I say African Americans and I say blacks because at some point, we have a lot of African Americans that come from very different places, as it relates to where you live in the country. So some of us who are African Americans never lived in a community where there were black people, right? Some of us live in a community where there's only black people, the lived experience. But it doesn't make a difference, because what happens with black people is that people see black first. That's what they see first. So it doesn't make a difference where you come from. It doesn't make a difference what economic status you're at. And that you see here. So for an African American or black person in this country, they still have the highest rate of death, no matter what educational level they're at. No matter what. There are more African Americans who are dying in pregnancy that have an education, a college education, than those who have a high school degree, a diploma. Why is that? It's complicated, isn't it? Okay, so what happened to Tori Bowie? You know Tori Bowie? Tori Bowie. Right, track star, Olympic star. What happened to Tori? Tori died at home by herself. That was, 2 months ago? Very recent. Tori Bowie, B-O-W-I-E, look her up. She died at home. She's an Olympic track runner. She had severe preeclampsia. She was termed, she was in labor, and she died at home alone. She didn't have any of those socioeconomic issues that we talk about. Oh, she's poor, doesn't have money, doesn't have a place to live. She had everything. Socioeconomically, she was fine. What happened to Tori? Most people think it was an education. She wasn't educated well. She wasn't a partner with her physician who told her the warning signs of preeclampsia. So lots of speculation of why this woman who had no issues died at home from severe preeclampsia. And here's the leading causes of maternal death. And so many of these you already know. You see it all the time, right? The mental health issue is a big deal, and we're starting to really focus on it, and I think that it's time. It's beyond time to focus on it. But many of these are the same throughout the entire world. As I've worked in many countries and taking care of women, the same things happen, especially health disparities. I have not been in a country where women of color have not been treated differently. Not one country. I've worked in many countries in Africa. I've been in India. I've been in Malaysia. I've worked extensively in South America. It is the color of the skin, it's the color of the skin that makes it a big difference. That's the reality of it. And we have to fix that. All right, let's look at maternal mortality. Again, when you think about what's up top, we always talk about Mexico, right? How bad Mexico is, right? And it is pretty bad, especially as it relates to death of moms. But look where we are. Not too far off. We're not too far off. All right, so where are we going? Everybody else is going up, we're going down. Just a verse. Everybody else is going down and we're going up. Let's talk about babies and why our babies are dying, right? This is just the definition, of course, of infant mortality. And this is the space that I work in a lot now. So that's just the typical definition. Now look and see where we are with our infant deaths. Shocked to anybody? Not at all. This is a definition of a crisis. When the WHO defines the health and the wealth of a country by the health of their children. The health of their children. We're not doing too well. Again, where are we as far as looking at wealthy nations? Look at that. You guys are awfully quiet out there. Okay, so this is the map of the United States, and you see where you are, where Michigan is at 5.42. Look at the worst places where babies are dying. Down in the South, right? And places where they've changed many policies around giving care using who's adopted the Affordable Care Act, right? Where are people living? How are people surviving? Most of the deaths, the highest deaths you see in the South. Okay, and then this is the leading causes of infant deaths. We can't do anything about birth defects, right? But look where we are with preterm labor, low birth weights. SIDS, we talk about SIDS not as often as we used to talk about SIDS, but we do talk about something else, right? We talk about accidents. We talk about sleep accidents a lot. What does that mean? Right? We've got pediatricians out there, right? Sleep accidents. This is when your baby goes home and they don't have anywhere for your baby to sleep. They're sleeping in the bed with the baby. This is when they don't have a pack of play. They don't have a crib. They don't have a baby box, right? Education and making sure we look at the social determinants of health when mom and babe goes home. Babies are dying more from sleep accidents today than they are from dying from SIDS in that postpartum period. How are we doing in Michigan? Now, this is the population of Michigan. 14.1% African American. Then it goes on, 0.7% American Indian, and on and on. But you are the 23rd most populous city in the United States. That's pretty heavy, don't you think? You got a lot of people here. This is the race and ethnicity in Detroit. Large population of African Americans. When you looked at those charts, the higher the rate, people of color, the higher the rate of death to moms and babes. There's no getting around it. I mean, the facts are the facts. This is data. Okay, now let's talk about how you're doing according to March of Dimes. March of Dimes does this wonderful thing, as you know, and they grade us. They talk about how we score. So Pennsylvania has a C-. We're not proud of that. But what in Michigan? Look at Michigan. It has a D+. It has a D+ looking at preterm birth, infant mortality. They break it down in the race as far as preterm birth. They actually look at low birth weight, very low birth weight, low birth weight. And then they look at the maternal vulnerability index. And this is the place where they look at where you live, what's your zip code, what's your socioeconomic status. Are you living in an environmentally unsafe community? Not that you have not only lead in your house, but are you living in a neighborhood of crime? So what's your vulnerability index? And then they look at clinical measures, and they compare whether you have a high or low cesarean rate. So very, very detailed. But the bottom corner here is really important, and I don't know if you can see that at all. But these are the check boxes that they want us to make, and the policy measures that affect you as a state. So Medicaid expansion, you did that. Medicaid extension, you did that. Midwifery policy, we have midwives. Maternal mortality review committees, we have that. Perinatal quality collaborative, you have that as well. And now we're looking at the doula policy. On the right track, right? Political determinants of health affect the social determinants of life. So in this corner, it looks like we're doing all the right things, right? From a policy standpoint, and how we're going to change this trajectory. This is just a ring, and I don't expect you to actually try to read this, but the key is that how did you get that D+, and how can you get better, right? Because when you look at how and where you see the holes in across the country, and so you're not exempt from that. There's a lot of things that we need to do to improve the life of mothers and babies right here. Okay, so how do we get health disparities? How do we get here? So, how do you think we got here? How did we get here? I mean, we're all good docs. We're all trying to do the best we can. But how did we get here in the first? Why am I here? Why did they hire me? You know, why did we hire people to talk about diversity, equity, inclusion in the first place? You know, because if we don't know the why, then we're not going to be able to figure out how to get from where we are today, right? And so when I talk about all the things that have happened historically, politically, another book is 100 Years of Obamacare by Daniel Dawes. Talks about all the political changes that have occurred over the years. All the books that Sharita showed about what's happening to your body, what's happening to women's bodies, the women's movement. All of that got us here. All of the not understanding that we do live in a country that was built on structural racism. It was strategic. It didn't just happen by chance. We created the word race, right? People are not dying because of their race. They're dying in this country because of other things, including racism. Now, racism then has put us in a situation where there's other things that come with that. Redlining. If you don't know the history, it's important for you to know the history because you have to know how we got here. Because we're still here. We still have homes. We still have the issues of redlining in this country. We still have the issue. I mean, 10 years ago, I bid on a home, and the bid was taken off the market because Black people had never lived in that community. And the white family was selling that house, so they could not be the first to sell a home in that community to a Black family. 10 years ago. So we're still there. But I could have been not only Black, I could have been a person living with disabilities. Challenges, many, many challenges as well. So we have to understand how we got here. And so we look at the health disparities that drive all these social and economic inequities. We're not talking about equality. We're not talking about, right? We're talking about inequities. Because all of us the picture of everybody who has a bicycle, right? Have you seen that before? The person who has a bicycle he's tall, the bike is too small. Someone who's in a wheelchair is given a bike but can't ride the bike because of the disability. But you give them a bike that is fitted for him or her, then they can ride the bike. They can be part of the whole crowd. They can be inclusive. So I show you this because racism and discrimination goes across all of these. When you talk about all the gaps we have, employment, housing, literacy, food security, social integration, and health coverage. Thinking about all of that, what happened to Tori Bowie? Right? Tori, she was employed, she had funds, she had housing, no problems with transportation. She was literate, but were we literate? There's two parts of literacy, right? Were we literate enough to tell her in plain English, what happens to you if you have an elevated pressure? What happens to you if you start to have a headache? What happens to you when you have pain? What does preeclampsia mean? So when we talk about literacy, it's not just about the health literacy of the patient. It's the health literacy of the provider. It's that patient-provider partnership that we have to start working on. Perception is reality. Many times when people say, well, that's just racist, right? It may not be racist. But to that person, perception is reality. We need to change that perception. And many times we can change that perception just by listening and giving people a voice and allowing people to have the dignity and respect that we give everybody else. And to really dismiss those stereotypes that we think about, that we all think about when we encounter our patients, when we encounter people on the street, when we encounter people at Walmart at 12 o'clock at night. You know, when they got those big old fluffy slippers on, walking through Walmart, and you get in line, you got one item, and they got a whole basket full of things, and they have 3 kids, and what do you say? Oh, my God. 12 o'clock at night, why are these kids in bed? And why does she have my big old pink fluffy slippers on? I've got one item, right? Instead of saying, maybe she doesn't have anybody to keep her kids. This is the time that she has to shop. Maybe those are the only pair of shoes she had to put on, right? But we all think things because of our lived experience. And we jump to these judgmental conclusions right away. So bias kills. And that's what we need to work on. Only one thing we need to work on. But all of these other things really affect what's happening with our moms and babes. Here are some of the disparities related to pregnancy. You've seen these before, right? Stillbirth, infant mortality. When I went to Guyana, which is where I currently work now, in Guyana, the stillbirth rate was ridiculous. My organization decreased the stillbirth rate by 25% based on education. Education of the patients and education of the providers. The providers who would walk and make rounds with you in the morning, and someone would be 34 weeks and baby would be dead, and they'd say, oh, baby's dead, and they keep walking. Changing the culture. Think about it. Our culture may not be that bad, but if we are not giving people the dignity and respect that they need as the partners with us, then we failed. Absolutely. So the death of moms in Guyana decreased by 50%. And why? Because we decided that we needed to make sure we had standards of care, evidence-based information, that we're all on the same page of how we're trying to practice and take care of women. That happens here. That's happening right here as you learn how to be great physicians and how you practice medicine. Abroad, those are the level sets that have to be made to make sure those women there are not dying. But in our own backyards, we have issues, many of those issues that happen. There's the pregnancy-related mortality rates. I'm not going to go through this at all. And then let's talk about racial discrimination very, very quickly. And basically, because it does have physiological and psychological impacts on women. And if we don't understand what happens to Black women in this country and their journey, then we can't understand how to intervene. And so we have to understand this whole issue of stress, toxic stress, microaggressions that happen every single day to Black women. All right, I'm in a C-suite. I have a meeting. We're talking about all the struggles we have with getting help. Right, we have to get help to come into the hospital. We need a neurosurgeon. We need doctors. We need nurses. Right, not at the facility I'm at now. However, all of these voids that we have to fill, I'm the only one in the room. Many times, I'm the only one in the room. That racial tax. And what do you think was said to me? Margaret, go to your communities. Go to your community. You all have a community, right? But go to your community. Tell your churches. This is a senior leader. Tell your churches that we are hiring. And where are we hiring? Yes. Environmental services. Because that's where you all work, right? Now, clearly when he said this, he didn't think about the fact that he said, Margaret, the only Black person, go to your churches and your community, right? And tell them we're hiring. Not that we need a neurosurgeon. We need environmental service workers, right? Think about the macro and microaggressions on the receiving end, the pain points that it goes on your entire life as a person of color, right? Now, what do you think I said? There's two things, what I said and what I should have said, right? So I said, well, who should they contact when I send this information? And he told me where. And so I left the room and I went, I called my husband, and I said all those 4-letter words that I say. You know I'm a sailor, right? I was military, I was Navy. So I can swear. So I said all those 4-letter words that I needed to say. And then I went home and I wrote the letter. And I wrote a really compelling letter and said, if you come into our institution at this level, you will have a bird's eye view of what you could be, things you could do, all the benefits you can have as far as you're growing, right? And this is a really important job. It is. And talked about the job. And I sent it out. And I sent it out to all the synagogues, all the places, every spiritual institution in the communities. And then I sent him a letter. I said, this is what I sent. It's going to give you a broader pool to hire from. And I hope that this helps. Right? And do you think it did anything? Did anything? It did. Because he came back to me and he realized what he had said. And he apologized. Right? The ouch, which was okay. I was feeling pain, but he had an ouch because he knew what he had done. That's the self-reflection and self-affirmation that doesn't happen sometimes that we need as individuals. So this whole issue of racial discrimination is significant because it sets up the stereotypes. Remember, this is you know this already, right? Lack of diversity, don't have, to get to me, I am one of 3 senior leaders, and the employee base is 40,000. So the pathway to get one of me is long, right? But it's important that I'm here. It's important that I'm here and I'm talking to you all, and this is my passion. But it's not about what I can do. It's about what all of us can do, right? Every white person sitting in this audience right here has responsibility to be an advocate for something, but I want to be an advocate for this. I want every white person to understand that this is not going to change without you. I can't do this alone. Historically, if you look back, the civil rights movement did not happen with just me, right? Everyone was at the table. We all have to be at the table for any of this to happen. So keep that in mind. And don't back away conversations that you feel uncomfortable with. You have to feel somewhat uncomfortable in order to move along, right? So when we think about what happens in our spaces and what happens in this learning and safe and healing space, we are all responsible for being advocates and for changing this. All right, is it bad for your health? Now, I put this up here because of weathering, right? So, you can take a moment to read it, but this whole issue of weathering, and who's heard the term before, weathering? Weathering, right? So, Dr. Geronimos, right? She talked about what does that mean? So what does that mean to an African-American woman? Think about this furniture that you sit outside winter after winter after winter. What happens to that furniture? It's old, gets rusted, deteriorated, broken down. The life of an African-American woman, from the time that she takes her first breath into the time she goes into a pre-pregnancy state, and then a pregnancy state and on, has been weathered. Now, you all are physician scientists out there. What does that mean? What about, you understand telomeres? What is a telomere? Telomeres are protective, right? Telomeres are the caps on the chromosomes in your DNA. They help you boost they're part of your aging process. They help boost your immunity, right? It's demonstrated by research that in African American women, telomeres are shortened. Telomeres are aged faster. So what happens to the immune system of an African American woman? What happens to the stress on an African American woman? What happens to the cognitive function on an African American woman? Why is an African American woman more prone to preterm delivery, preterm labor, preterm delivery. The science is the science, and we have to understand the science. But if we don't understand how we got here and how even prior to the pregnancy journey, a Black woman comes into your office already weathered. And so understanding that can make a difference in how you form your patient and client relationships. And so when you hear this, you understand what it is, weathering. People talk about it all the time. So what can we do to address this? Okay. We talked about, I started here, right? Trust. What happened to the pandemic, right? All the trust that we wanted people to say, come on and get your vaccines, right? Didn't happen. Okay. So trust, we start there. All right, so this is a statement that was by the March of Dimes, basically just how we're going to eliminate health disparities. And it's really focused on awareness, advocacy, data collection. So I'm not going to read this to you, but you're going to have these slides. But some of the things we need to think about all the time. This is a statement from ACOG, right? So everyone who's in this space who knows we want to give good care to everybody has made a statement about this. Our position statement from the midwifery, American Society of Nurse Midwives. And then this is also what is so important about maternal health in the rights of women. So all of these folks, all of these organizations who are with us, who care, have made these statements. Whoops, what did I do? Okay. This is the pillars of organizational change that I created, that we use in our system, that they still use in Cleveland. And this is how we internally look at who we are, right? So let's look inside, my friend says, look inside before you decide. All right, let's talk about what happens in our own system. Are we all educated about how we got here? Our senior leaders, everybody in our system, how can we govern if we don't know how we got here in the first place? How can we be creative to think about how we move on with no blame or shame? And so that's one of the pillars, which is educate. Also, one of the biggest pillars is how do we investigate in our own system? Right here, how do we look at our policies and procedures to see, are we doing something? Do we have a policy that really is raising this ugly head of sexism or racism or any ism? Let's look inside. And that's what these pillars are for. The last one we're going to talk about here is also invigorate. How do we pay for this? How do we pay for all this? Because it can't be a one-off. It has to be sustainable. This is how we save money. Think about it. This is what it looks like in Pittsburgh. Just look at the right-hand corner over here, where potential medical cost savings is $9 million, potential societal savings is $38 million. So if you ever want to talk about how we know that this is important and diversity, it makes good business sense, you can prove it makes good business sense by talking about if you save lives, how do you save money? Less emergency room visits and on and on. And I got a short video to show you. It gives an overview of a program that we started in Cleveland. It was in Cleveland. It was called First Year Cleveland. And then I took that concept to Pittsburgh and created First Steps and Beyond, and came up with a system that we're working, which is community centered. So, and this tells you a little bit about it.
So I remember, like it was yesterday, I woke up, I think it was a Monday morning. My husband and I, we got in the car, went to the ER. The first thing he said, "Hey, are you in pain?" The answer is no. And they're looking like, okay, you're not cramping. No. Why am I bleeding? Preterm labor can happen to anybody, no matter what color you are. I went into labor prematurely. They couldn't stop it because it was true active labor, and that is why I had Logan so early. So, I remember the look that you gave me, Dr. Udrea gave me. Like, you're doctors, so you can't tell me what I want to hear. And what I wanted to hear was, Kia, he's going to be fine, because it's not a guarantee. And I just like, is he gonna be okay? Is he gonna make it? Like, save him. Don't worry about me. The hallway was so long to the NICU. And when I saw him, I remember he put his arm up. And I was like, you got this, Logan, you got it. I think that when we decided to stop, I kind of stopped in a moment because I was like, I thought I could do more. And again, we can't do more. We have to accept that this was God's plan. He was here for 8 hours, and that was a blessing because everyone was not expecting him to be here for 8 minutes. So we were able to spend 8 hours, and I wouldn't take that back.
The United States has higher rates of maternal and infant mortality than any other wealthy nation. Each year in this country, around 20,000 infants die due to birth defects, preterm and low birth weight, injuries, SIDS, and pregnancy complications. The perinatal outcomes in the United States are alarming and exacerbated when we look at the outcomes of Black mothers, birthing people, and their babies. These outcomes did not happen overnight and have been centuries in the making. Racism in the United States have led to centuries of trauma, violence, stress, and discrimination against Black women, birthing people, and their babies. Throughout the 20th century and up to today, these abuses and mistreatments continue, leading to lack of quality care, inadequate support, and patients are blamed for their negative medical outcomes. This history of blame puts the focus on individuals and families rather than recognizing this is a national crisis. Thankfully, however, the percentage of birth workers is increasing. Committed to the principles of reproductive justice, they are helping to improve these outcomes and empowering Black families.
First Steps and Beyond is working to reduce Black infant mortality through an interdisciplinary approach. We are blending lived experiences, evidence-based interventions, and the expertise of the entire collaborative. Our goals are to reduce racial disparities and preterm birth rates, eliminate sleep-related deaths, and expand the postpartum period support, also known as the fourth trimester. It's a program that is especially critical here in Pittsburgh, where 15 out of every 1,000 Black babies born will die before their first birthday. We aim to provide inclusive health care throughout the pregnancy journey by implementing Centering Pregnancy, which is an evidence-based model of community prenatal care, developing a community-informed training on obstetric racism, conducting a birth equity assessment, participating in a doula working group to improve relationships and policies, hosting a Mothers of Color support group through the Alexis Joy Center in partnership with Brown Mamas and Healthy Start, and finally, outlining benefits needed for improved maternal and infant health outcomes. We are dedicated to this important work and are excited to find even more ways to collaborate. We have amazing partners like Pittsburgh's healthcare systems, community members, doulas, community-based organizations, and government, and we're currently participating in some of their initiatives as well to co-create a unified strategy that will address both medical and social needs through an equity and social justice-centered lens. Together, we can stop the preventable deaths of Black babies and mothers.
Areas of concentration: obstetric racism, preterm labor and delivery, sleep accidents, and increasing the postpartum fourth trimester support. And in our system, we've seen a 9.8% decrease in the death of Black moms. So it works. So that's where we are. I'm going to stop here. It's a crisis. We have to figure out a way to do this. All of these community organizations came together in one space, not working in silos, very difficult to do. People want to have to leave their egos at the door. But it's working because we've all come together, no matter what we have gained as far as our own incomes and our own funds to run our own programs. We've come together using funds that have been now dedicated and contributed to this particular program so that everyone in the city, in the county, that touches a woman, any woman, will have all of these things, obstetric racism training, et cetera, et cetera. So that's it. Questions? Multiple funders. We have PNC Bank, Heinz. They're all philanthropic funding. That once we came together and said this is a community effort, community-driven effort. That if you know Pittsburgh at all, University of Pittsburgh Medical Center, Highmark Allegheny Health Network, very, very competitive. All of the FQHCs, Midwifery Center, all of us came together and said anyone who touches a patient, anyone who does an intake on a patient, will go through all the training to understand how to recognize whether it's perception or reality, how to give people dignity or respect so that you get people on the same page, so you're doing something that's literate, so that patients understand that they can make this journey in a safe way with a trusted provider and practitioner.
Thank you for a great presentation. You mentioned the fourth trimester and the postpartum deaths that were happening in the mental health crisis. Can you say a little bit about strategies that you would recommend there?
So it's at Alexis Joy Center in there. Alexis Joy was a white woman who suffered severe postpartum depression, committed suicide, and her family set up this behavioral health center that we work with, and I'm sure hopefully it's a behavioral health center in the places that you work at. But basically targeting opiate addictions as well, really making sure we have multiple touch points with patients once they leave from that center. So it really is trying to give this wraparound care, but really focusing on mental and behavioral health more than we've ever done before. Because they go into depression, they're by themselves. They take maybe their lives and their babies' lives as well. Questions? Either I've told you all you want to know, or I did a horrible job with the other. So, all right, it's been a pleasure. Thank you so much.
Okay, let's give another hand clap for Dr. Pettigrew. Thank you. She did give us a little glimpse into her life as she shared her son and his family story, but she also has a book sale, which is called The Colors of My Heart, Embracing My Blackness Through History, Family, Fear, and Faith. She will be signing these books in the lobby. This book gives a deeper dive. It talks about the fear, pain, resilience, forgiveness, and inspiration through a lens of multiculturalism. So you get a deeper dive into the journey of her life story. So she will be in the lobby to sign those momentarily. And we have our workshop sessions coming up. It's a repeat of the morning sessions as you see in your programs. Session 1, which is here in the auditorium, Ethical and Practical Challenges in Studying Health Equity. Session 2 is Breast Cancer in Underrepresented Groups, Classroom 110, Mental Health Disparities, 111, Disparities in Abortion Care 210, and Health Equity Inequities in Maternal Immunization Lessons Learned from the COVID 211. So we will see you back for closing remarks after those workshop sessions. Thank you.